So we have a great discussion and presentation today on the extrapulmonary presentations of COVID-19. This is work done from our AFEM team and particularly the rapid review team, which has been continuously producing really important information about COVID-19 for the past couple of months. And our presenter is Dr. Lauren Lai King. She is a specialist emergency physician and also an academic convener in the emergency medicine postgraduate registrar program. She works for the University of Cape Town and Stellenbosch University and is based in Cape Town, South Africa. And she's also been one of the leading team members in the rapid review project. So we're really excited to have her, and I'm going to hand it over to Dr. King now.
Wonderful. Thanks for that introduction, Rory. And thank you to Steve and the AFEM webinar team for making this possible today. Good afternoon, everyone. I've been personally following the AFEM COVID webinar series from the start, and it's been such a valuable experience to learn from the emergency care community throughout the African region. And so it's really my privilege today then to share with you a brief overview of what is currently understood about the extrapulmonary presentations of COVID-19, followed by a discussion of a series of cases. It's one thing to read about COVID in the literature, but in many ways, for me at least, the lessons learned through firsthand experiences have a greater and longer lasting impact. And I hope to convey some of that with you today. My focus today will be on adults, as Andrew Redfern presented on the pediatric considerations last week. And so perhaps let me start by setting the scene for you with a couple of background stats. The WHO African region has a little over 834,000 confirmed cases, of which South Africa accounts for an estimated 52,000 of those cases. In terms of the situation by country, South Africa is currently ranked as the 5th highest in terms of number of confirmed cases, behind the United States of America, Brazil, India, and Russia. Cape Town, which is where I'm based, started as the epicenter in South Africa, but that has now shifted to the Gauteng province, who currently account for approximately 35% of the confirmed cases in South Africa. It is likely that we still do not have a complete understanding of the pathophysiological effects of the SARS-CoV-2 virus. And while we're becoming more comfortable with the acute presentations, we are aware that there probably is a lot that we still don't know and don't understand about the long-term sequelae. In terms of our understanding of the extrapulmonary effects, even in the early stages going back to March of this year, the scientific community presented data to support the COVID-19 manifesting multiple systems and not an isolated organ system. This is a graphical representation of a preprint meta-analysis examining potential target cells of the SARS-CoV-2 virus. Although SARS-CoV-2 is recognized for its respiratory complications, we know that the virus enters the host via the angiotensin-converting enzyme 2 receptor. And it is because of this mechanism of receptor binding and those receptors being expressed in various organs, the pathology then that occurs during the primary phase of infection is multi-system and translates into the varied symptoms associated with clinical disease. This has become a frequently shared image in recent months on the proposed time course and disease severity of COVID-19. Siddiqui et al. Reported 2 distinct but overlapping pathologic subsets. The first is triggered by the virus itself, and the second by the host response. The stages aren't discrete, and progression from a viral response to a predominant host inflammatory response corresponds with clinical decline and progression in disease severity. And so the way in which this ties in with the extrapulmonary presentations is that the host inflammatory and cytokine response corresponds with an increasing incidence of the extrapulmonary consequences of the disease process, including, but not limited to, acute kidney injury, myocardial injury, neurological insults, and disturbances in coagulation. Most often, these pulmonary manifestations are also indicators of severe and critical disease and serve as red flags to expedite and escalate to an intensified bundle of care. The WHO estimates that approximately 75% of COVID-19 patients requiring hospitalization will be classified as severe and 25% as critical. It is estimated that the most common case definition of cough and fever, if strictly applied, would miss 7% of hospitalized COVID-19 patients. And so from our anecdotal experience in Cape Town, it's imperative not to underestimate the extrapulmonary manifestations of severe and critical COVID-19 disease, which can rapidly progress to significant morbidity and mortality if not acted on early on. As Rory mentioned, the Rapid Review series is one of our COVID-19 projects that was developed by the Division of Emergency Medicine in Cape Town and the African Federation of Emergency Medicine. It's a collaborative project that was driven by a need to synthesize, simplify, and contextualize the large volumes of literature being shared by the global scientific community, often to the point of being overwhelming and quite confusing. And in many respects, the Rapid Review series has become somewhat of a timeline of the clinical impact of COVID on our health service, particularly in Cape Town. Rapid Reviews 11 and 12 were developed in late June and early July on the extrapulmonary manifestations of COVID-19 disease, because at that time, in the center that I work in, we were experiencing a peak in cases, a peak in morbidity and mortality of severe and critically ill patients, and we were being called out and challenged by the atypical COVID-19 presentation. And so we created these two rapid reviews in an effort to better understand how to optimize our management and improve clinical outcomes. The rapid reviews are available on the AFM social media platforms, and so I won't repeat that content today, but rather share a few of the challenging cases that unmasked our gaps in understanding and pushed us to create Rapid Review 11 and 12. Case 1 is about Mrs. HGT. She was a 52-year-old lady with a background of type 2 diabetes who presented to our emergency unit with a short history of gastrointestinal upset, and on clinical review was assessed to be confused and altered. Her admission vitals were concerning for low oxygen saturation in room air, but with no overt signs of respiratory distress. And the bedside finger prick blood glucose test simply read high. In view of her background of diabetes, a blood gas was performed. And this is her series of blood gas printouts over a period of 12 to 18 hours. And so let's just take a second to unpack these a little bit. I don't know about you, but my eye is immediately drawn to the profound uncompensated metabolic acidosis, which improves over time, but doesn't really ever fully correct, as well as the persistent hyperglycemia. Another worrying initial disturbance is the elevated lactate of 6.7, but that reassuringly appears to be clearing by the third gas. And interestingly, the potassium appears to drop on a downward trend from 5.7 to 4.7. And so with that information on the first blood gas analysis, a diagnosis of hyperglycemia with profound metabolic acidosis secondary to a diabetic ketoacidosis was made. And subsequent to that, fluid resuscitation and an insulin infusion was commenced. Now, the continuous insulin infusion would explain the cause for the drop in potassium as seen on these repeat blood gases. But what remained an initial diagnostic dilemma for us was identifying her underlying precipitating event that triggered her DKA. The chest X-ray soon revealed bilateral peripheral lower zone predominant consolidation, suggestive of a COVID pneumonia, and a subsequent PCR swab was performed, which came back SARS-CoV-2 positive. And now looking back, early on in our COVID response, the significance of glucose dysregulation was underestimated, and in the absence of respiratory symptoms, we often failed to consider COVID pneumonia or even multi-organ COVID involvement as the top differential diagnosis on more than one occasion. What we now know, and in fact the literature shows, that diabetes is an independent risk factor for severe disease, rapid progression, and poor prognosis. COVID-19 disease precipitates atypical presentations of diabetic emergencies, and the implication of this is that early identification and management of hyperglycemia in COVID-19 patients is critical to improve outcomes. And patients with diabetes or hyperglycemia have a four-fold higher in-hospital mortality rate compared to those without evidence for diabetes or uncontrolled hyperglycemia. The reason for this mortality risk is multifactorial, but largely underpinned by the challenges faced in every area of our targeted management. Fluid management is a challenge, as the lungs are predisposed to being leaky and thus easily pushed into pulmonary edema. Insulin requirements might be increased due to infection, and COVID as a driver appears to cause the DKA to persist for longer. Often, the iatrogenic consequence of prolonged insulin administration is hypokalemia. And while this wasn't a real issue in our patients, there was a clear trend down in the measured potassium on our blood gas readings. The correction of hypokalemia in and of itself poses another challenge because continuous renal potassium loss resulting from the degradation of angiotensin converting 2 enzyme. In fact, the high prevalence of hypokalemia among patients with COVID-19 suggests that it's not only the effects of insulin administration, but also the presence of disordered renin-angiotensin system activity, which speaks to the acute renal injury of COVID-19. And so when it comes to COVID-induced acute kidney injury, the most important consideration is to prevent and decrease the severity of the initial renal injury and prevent iatrogenic worsening of renal injury. This is achieved through avoidance of nephrotoxic agents, careful dosing of medications with nephrotoxic potential, and continuous evaluation of fluid status and fluid responsiveness. Following the lessons learned in cases such as this and many others, we then adapted our local COVID-19 clinical management guidelines such that diabetic emergencies are classified as a red flag presentation, and SARS-CoV-2 PCR testing is recommended in all patients presenting with glucose dysregulation, even in the absence of typical respiratory symptoms or in the absence of meeting the NICD case definition. Case 2 is Mr. M.I. He is a 58-year-old gentleman with an excellent functional baseline who presented with a typical cluster of symptoms suspicious for COVID pneumonia. He tested SARS-CoV-2 positive and was admitted on the basis of hypoxia and bilateral pneumonic changes on chest X-ray. His clinical course was largely uneventful, and he appeared to be recovering well until a sudden and rapid clinical decline on day 5, when he developed acute heart failure with severe hypoxia and a hypoxic delirium. His ECG was scary, to say the least, and it demonstrated widespread ST segment elevation and T-wave inversion, which, together with a troponin leak and echocardiographic evidence of globally impaired cardiac contractility, suggested cardiogenic shock secondary to viral myocarditis. This is just one of a spectrum of presentations of COVID-induced myocardial injury. As with glucose dysregulation, this entity is not to be underestimated, and there is a growing body of evidence to support that patients with cardiovascular comorbidities are at increased risk of severe disease and complications of COVID-19. As demonstrated in this case, myocarditis appears in COVID-19 patients several days after the onset of fever and should be considered as the precipitating cause in a patient presenting with undifferentiated cardiogenic shock. And in fact, in any case of COVID disease in which hypoxia is prolonged and not improving, one should consider the possibility of cardiac failure. It's also important to remember and be aware that ST elevation myocardial infarction may be the presenting complaint and the first clinical manifestation of COVID-19. Okay, on to my last case. Mrs. PE, a 58-year-old lady, presented with cough and breathlessness and a positive SARS-CoV-2 PCR test. We admitted her for respiratory support, and she initially responded well with face mask oxygen and prone positioning, but required escalation to high-flow nasal oxygen within 24 hours. The patient did not require further escalation of her respiratory support and continued to remain stable, but did not demonstrate marked clinical improvement even at day 7 and 8 of her admission. On day 9, she rapidly deteriorated and within 2 hours went into cardiac arrest and sadly demised. And so after what I've just described, you may well be thinking that this patient is likely to have developed acute decompensated heart failure, possibly due to a viral myocarditis. And while myocarditis was definitely high up on the list of differentials, this is not what happened with this lady. This patient was admitted at one of our tertiary level hospitals in Cape Town, and we were able to obtain a CTPA, which, as you can see, did not confirm a viral myocarditis, but it did show a large saddle pulmonary embolus, resulting in her sad demise. So let's talk a little bit about COVID-associated coagulopathy. It remains a poorly understood clinical entity, but what is widely reported in the literature is that there is a very high cumulative incidence of thrombotic complications in critically ill COVID-19 patients. The optimal preventative strategy, including risk assessment, dosage, and duration of prophylaxis, are under investigation. And the effective dose of both prophylactic and anticoagulant heparin therapy is not yet clear. And so in this regard, we are awaiting the results of multiple randomized control trials to help guide our therapy and management approach. So it's a short, sweet, and succinct overview of a couple of cases that have been particularly challenging to our clinical team in the past few months. And I hope that this has been a helpful recap of cases that have had an impact on us and is an opportunity to learn from some of the mistakes that we made along the way as you face your own clinical dilemmas and conundrums in your own units. My take-home message is really quite simple, and that's to remember that COVID-19 is not a purely respiratory pathology, but rather a multi-system clinical entity. And I hope to have highlighted through my presentation today that the extrapulmonary presentations are often a red flag for severe and critical disease that warrants rapid escalation of care in order to prevent morbidity and mortality. Thank you so very much for your time and attention. I'm happy to take any questions or comments.
I'm going to ask the question for Emeka Elumelu because it doesn't look like you're able to enable your audio. So I'm just going to ask the questions to you, Dr. King, if that works.
Yes,
so the first is, how do you determine the red flags for CAC? Forgetting what the acronym was for. For COVID-associated coagulopathy. It's a mouthful.
Yeah, it's a real mouthful. It's a mouthful and a clinical challenge, actually, and I think that that's a great question. Thank you very much for that. So the red flags, essentially, when it comes to associated coagulopathy, is quite tricky because it can often be fairly subtle and can creep up on you if not actively looking for it. And essentially, what one would be looking for would be evidence of venous thromboembolic events or even arterial events. And so the kinds of conditions that we're seeing in terms of presentations is we're seeing presentations of deep vein thrombosis. We're seeing presentations of pulmonary embolus. We're seeing evidence of mesenteric ischemia, and sometimes even arterial thrombosis, even in large vessels such as the aorta. And just through the mechanism of being afflicted with COVID-19, the SARS-CoV-2 virus causes an endotheliopathy, and it causes endothelial damage. And so just by virtue of having COVID-19 disease, that in and of itself is a red flag for coagulopathic downstream effects. And there have been a couple of studies that have done kind of a side-by-side comparison of those patients with COVID-19 with a matched control, and those with COVID-19 are at increased risk of coagulopathy. And so really just through having COVID-19, one needs to have a high index to suspect any kind of thromboembolic kind of phenomena and coagulopathic disturbance. The coagulopathic disturbance that is described is largely thromboembolic in nature and less predisposed to a bleeding tendency. So definitely look out for things that would suggest thromboembolic phenomena, such as, in the case of a DVT, a swollen, painful unilateral limb, whether that be a lower limb or an upper limb. In pulmonary embolism, unexplained hypoxia, or a sudden increase in work of breathing. And then in terms of things like mesenteric ischemia, it would be pain out of proportion for a clinical entity, or an unexplained rising lactate on a blood gas.
Great, thank you so much. I'm going to move on to our next question, and we actually do have someone who has their audio enabled. So I'll return to Emeka's remaining questions following that, but I do want to get to some of our attendees who have their hand raised. So Rotimi Akinola, I'm going to unmute you so you can share your experience and ask your question. Try to test your audio.
Hi, good morning. Good afternoon, everybody. Sorry.
Hi, how are you?
I'm well, thanks. Thank you for the presentation. I was just saying that, like Dr. King said, we've had quite a number of the hyperglycemic patients, diabetic patients, both known and what seemed like not known, and coming with these manifestations. One of our very interesting cases, or the patient who came, ended up having SIADH. Was really a balancing act with his fluids and his output. We kind of got on top of it eventually. So along with all the other management for the COVID, his antibiotics for his sepsis, his dexamethasone for we also now had to start putting him on desmopressin, sorting out the SIADH. And well, on a good note, he did settle. We also had another significant one where we had rhabdomyolysis, and also patient did quite well, but these are patients we already knew were COVID positive, so maybe that was kind of the cheat sheet we had, that we knew they were already COVID positive patients, but they now had these other manifestations that came along with it, with all the other things we saw along with them. Managed in the ICU, and then stepped down eventually to HU to discharge.
Wow, that's incredible. Yeah, it sounds like you did such a great job with really challenging cases, and I think that that's really been our shared experience, is that we often are presented with these very atypical presentations, and it's difficult really to know what's attributed to the COVID and what's happening as downstream, effects as a result of a multi-organ compromise and shutdown. So certainly in our center, we've had to collaborate widely with a range of specialists. And so oftentimes it's not just the emergency physician that's the primary physician, but rather we're collaborating with the hematologists and the nephrologists and the critical care physicians and that kind of thing. And we are very fortunate to have that range of expertise available to us. But it's really tough when you find yourself in this difficult position of not really knowing why these presentations are so front and center when it's not really being described commonly.
Yes, thank you so much for sharing. I'm going to move on to our next set of questions. And we do have more hands raised and just trying to work with those people so that they can get their audio enabled. So we will get to you. But a couple of questions that we did have come through that I will ask is, when you've identified, I think either COVID-19 or CAC, for how long will you give prophylactic drugs?
Again, such an interesting and difficult question, actually. So the jury is still out, largely, when it comes to anticoagulant therapy, both prophylactic and therapeutic. The recommendations generally is that for those patients who present with severe disease and progress to a critical illness, that prophylactic anticoagulation is no longer sufficient. And actually the recommendation to mitigate and to prevent the COVID-associated coagulopathy is to actually then escalate to therapeutic doses of anticoagulant therapy. In our center, what we are using is we're using low molecular weight heparin, and that has been variably effective. So even as I noted in the slide, even with thromboprophylaxis, thrombosis occurs in 20 to 30% of critically ill COVID-19 patients, which is why we moved to starting therapeutic anticoagulation. In terms of the dosing of therapeutic anticoagulation, that also remains somewhat of a gray zone, and there isn't really consensus across the bodies and committees of experts. So the International Society for Thrombosis and Hematologists have said that they're quite aggressive. They say that therapeutic anticoagulation is started when critical illness is suspected. And they even go so far as to say that anticoagulation should be considered as an outpatient modality. But, it's really around the risk benefits of that kind of thing, and not all systems are set up for that. So definitely anticoagulation is warranted during the inpatient management of the COVID-19 disease, and then the jury is out in terms of whether there is benefit to continuing anticoagulation, but with a prophylactic dose as an outpatient once the patient is discharged.
Thank you for the response, and I'm going to move on to our next question. This is from Rajani, and unfortunately, they're unable to enable their audio, so I'll ask the questions for them. So this is a comment from Uganda. Many complain about peripheral neuropathy and GI symptoms like epigastric pain or exacerbation of pre-existing symptoms of acid reflux disease. What is your observation among your patients who are able to communicate?
So I 100% would agree with that. I think that we are also seeing a range of gastrointestinal complaints. It speaks again, to the slide where it shows that there are just a range of target organs that can be affected by SARS-CoV-2. And if one were to look at the effect on the gastrointestinal system, it is believed that SARS-CoV-2 enters through the epithelial lining of the gastrointestinal system, as well as through the. And so we are similarly seeing a range of gastrointestinal upset from just very mild nausea and vomiting to not commonly, but we have seen some reports of liver failure.
Great, thank you. And then this is a similar question than before, based on sort of prophylaxis, but a bit more specific, also from Rajani. And the question is, when do you start VTE prophylaxis? Do you start on all symptomatics, or is a decision made based on D-dimer?
So D-dimer, that's an interesting question. Thank you very much again for some really thought-provoking questions. In terms of our protocol for commencing anticoagulation, we start prophylactic anticoagulation and prophylaxis for all patients that are admitted, irrespective of whether there's a D-dimer or not. In those patients who then deteriorate and we're unsure as to what could be the reason for that, whether that's COVID-associated coagulopathy or whether it's related to another organ system. In that case, we would use D-dimer to guide our management. And so then we almost look at D-dimer as a trend. And if D-dimer is then trending up, we're in conjunction with clinical deterioration, we will more actively seek out coagulopathic related complications. And so that means that we would try and get the patients a bedside ultrasound, possibly even send them in for a CT scan to try and identify whether or not there are larger coagulopathic events that are happening. But we don't typically use D-dimers to guide the initiation of thromboprophylaxis. That would happen for any patient that is admitted into hospital.
Great, thank you so much. And I do have another question for you. Sorry, these are a bit of a rapid fire. And just as I do ask this question, I want to reach out to see if anyone else has any experiences or non-respiratory cases that they want to share about. I do see that some of you have audio enabled, so we'd love to hear from you. And if you just want to raise your hand or submit in the chat that you'd like to share your experiences, I can then work with you to enable your audio and unmute you to share your experience as well, so that we can hear more about all the different experiences you all are having. But this question is, how important is positioning when doing patient management?
Yeah, thank you very much again for that question. Patient positioning has been really helpful for us. I think we've learned a lot from our pediatric colleagues, whereby the children are frequently prone, and they find that those with respiratory symptoms do quite well when they're in their tummies. The pediatricians call it tummy time, and we call it prone positioning. So we have found really good response to a subset of patients who probably are not going to progress to critical illness. So prone positioning is definitely helpful as an awake and as a stated modality. In the subset of patients in whom they are able to awake prone, it definitely gives us some time, but we don't believe that it necessarily reverses the disease process. It just helps with the VQ mismatch that results from the SARS-CoV-2 related COVID pneumonia. And it sometimes gives us an indication of how responsive patients are going to be to the initial interventions. And in the case that prone positioning is not proving helpful or not displaying any improvement in condition, we then have a higher index to suspect that the patient is going to rapidly progress to a more serious and critical illness, and then we are more inclined to escalate our bundle of care a little bit more rapidly.
Awesome, thank you so much. And then another question has come through. So just getting to it. This question is about sort of the primary mechanism for all of these extrapulmonary manifestations, is it purely immune dysregulation? Or is there some other element that is sort of the primary element driving these manifestations?
Yeah, I think it's a great question, and I think it's difficult to give really declarative answers at this stage, because a lot of what we know is kind of what we hypothesize, and it's not really been well validated in large studies at this stage. So I think what we do know is that, as I showed earlier in this presentation, it was really a mix of the viral host response and then the post-inflammatory response. So much of the extrapulmonary manifestations, I would agree with you, is largely driven by the inflammatory response. But in many cases, it probably is a combination of both direct viral impact, as well as the knock-on downstream effects of the inflammatory cascade.
Awesome, thank you. So we're just, we do have another question that's come through. So I'm going to, I'm not sure that this person is able to enable their, actually it looks like they are able to enable their audio. Let me just send a quick message and double check that, because it's unclear. So just stand by, everyone, and continue to submit your questions as I work with this person to submit their question. But maybe in the meantime, Dr. King, would you be willing to talk a bit more about the process that you guys go through in terms of producing these rapid reviews? We did have some questions early on about where to access them, and I have provided that link, but just a little bit more about how people can access them and what information you guys might be looking into currently.
Yeah, of course. So the rapid reviews was really a real passion project, essentially. It just came out of the need to try and refine the bottom line from a wide and overwhelmingly rapid rate of new information and literature that was being put out. So one was that we knew that there was a lot of literature that was coming out. Two, we didn't know what was the quality of that literature. And three, very little of the literature that was being sent out and developed early on was being developed by emergency care physicians, or was being developed with the emergency care physician in mind, or for the purposes of emergency care services and acute care services. And so as we were trying to put in place our strategic planning and our preparation, we weren't really sure what to do with this literature. And so we ended up trying to synthesize it into very manageable bite-sized pieces. And that really is what happened around the rapid reviews. And then we assigned a really catchy title to it. But that the purpose of the rapid review was really just to help guide our management and to try and make sure that we had the best chance of good clinical outcomes where possible. And our process of rapid review development really comes down to identifying a question that we've identified through our own clinical practice. So there's not that much of a scientific process that goes into identifying the topics, but rather it comes out of a need. So we are constantly talking to our clinicians on the front line and on the shop floor. We are constantly sharing and comparing notes with one another. And when we find that there's a particular question that's a real sticking point for us, we look and see how and where we can find the latest evidence. We search widely in terms of the literature that we are pulling from. As far as possible, we like to use peer-reviewed literature and articles and research. that is not always possible. And where that's not possible, we will say that it is a preprint article or it's a non-peer reviewed article. But where possible, we are trying to keep the rapid reviews as robust as possible. And so we're looking at a range of literature and databases and journals. But as we move forward, I don't know that the rapid reviews are going to be as necessary, because now we have a lot more emergency-based literature that's coming out. So we might find that the rapid reviews become a little bit redundant moving forward, but certainly they served a real purpose for us in the first couple of months.
Great. Thank you so much, Dr. King, for sharing that insight. And we do have just a couple of comments and experiences that those are that a couple more people are sharing. Unfortunately, they're not able to enable their audio, but I am going to sort of share those out. So the first is from Moses Dodu from Nigeria. So first of all, he says, thank you profoundly for the educational presentation and for the well-ordered moderation. So thank you so much, Dr. King, for that presentation. And his comment and question are as follows. In tropical Africa, particularly Nigeria, a couple of patients, including colleagues, present with symptoms of malaria, and due to its endemicity, the index of suspicion for COVID-19 only increases after repeatedly failed anti-malarial therapy, and sometimes wherein there is dyspnea and a loss of ability to smell and taste, but by which point this person-to-person transmission would have already pervaded the environment due to the late presentation of symptoms. So the follow-up question to that is, what can we do towards early diagnosis of non-classical presentation of COVID-19 to ensure that we have curbed the spread, considering the resource deficiency in terms of testing in Africa? So Dr. King, what are your thoughts on that?
Gosh, I think that that's a really challenging question, and it's something that every system and every region will have to individualize for themselves, I think. So, when that would be something that I am not acutely familiar with, because malaria is not endemic to the center that I work in. But certainly the kinds of things that have helped us in terms of identifying early on cases that are at high risk were to put in place screening processes. So we have, I think I shared it in my presentation, let me have a look. What we did is we developed a screening tool. And so this screening tool was guided somewhat by our case definition that was being distributed at the time. But then similarly, in addition to the case definition, we then identified for ourselves within our specific centers what the red flag presentations were. And now a lot of these red flag presentations are now widely described in the literature as the extrapulmonary manifestations, with neurological compromise and glucose dysregulation and myocardial injury and so on. But my suggestion then would be to try and identify those early on, is to put in place robust screening processes and identify for yourselves what would be the red flag presentations that are coming up frequently.
Great, thank you, Dr. King. And we also did have a comment from Rajani, who is based in Uganda, saying, sort of on the similar vein of malaria, they do mandatory malaria rapid testing and HIV testing to rule out those two diseases as the cause of the symptoms and manifestations. So something interesting to consider, but also, can be challenging given the lack of resources or lack of testing potentially for even malaria and HIV testing. Yeah. So we do have another question that's come through. Ken, do you want to ask your question? I think your audio is enabled.
Hi, Ken.
Hi, great presentation. Hi, Lawrence. It's not a question per se. Can you hear me? Can you still hear me?
Yes, we can still hear you.
Yes, it's actually a case that was discussed a week ago. It's basically a CVA in the context of COVID. I don't know if in your setting, if you have any experience or any incidents of those cases of patient presenting basically with signs of CVA in a context of COVID. And in that line, the discussion was about the change, of approach in thrombolytic therapy in that context. I don't know if you've come across anything along those lines in the literature. That's what I wanted to say.
Yeah, 100%. Thank you very much for that question and comment. So much of the neurological insult that is being reported is related to the coagulopathic manifestations. And so, as you say, the stroke presentations are largely as a result of the thromboembolic implications, but there are also, as mentioned earlier, endothelial disruption and endothelial injury, from which the blood vessels within the brain are not spared. So there is definitely a risk for stroke, and stroke is one of the debilitating presentations that can present as one of the neurological manifestations of COVID-19. In terms of thrombolytic therapy for stroke, I think whether you're talking about COVID-related stroke or non-COVID-related stroke, thrombolytic therapy is fairly controversial. And so it's difficult to answer that as like a blanket statement. I think you definitely have to engage with the services and the colleagues and the specialists that you are working with in your facility to see whether or not thrombolytic therapy is something that you would like to offer as your package of care. Certainly, the management of COVID-related neurological insult is maybe not so different from general neurological insults, in that our priority is to prevent the secondary neurological effects. And so that probably would be the best advice that I can give you at this stage. Not very definitive, unfortunately.
Thank you so much, Dr. King. We are close to time and we have 2 remaining questions. So I think this is going to be where we cut off questions, but thank you all for providing such important questions and reflections. So I'm going to ask these last 2 questions. So the first is from Simone, and this is respiratory related, but considering that you do work in a hospital with a variety of manifestations of COVID-19, figured we'd ask it anyways. So what is the best way for a COVID positive patient to treat dry cough?
I think when it comes to the cough itself, it is very difficult to treat the cough. And so my suggestion would be to monitor the patient and to risk stratify the patient in terms of their severity of disease. And so the cough in and of itself is not something that we would be acutely worried about. I think it would be in terms of the oxygenation and the concerns around whether or not there are complications related to hypoxia. The cough itself, while being quite uncomfortable for the patient, is unfortunately not something that we can really suppress, and don't really advocate for cough suppressant type of interventions. But it would be important to risk stratify the patient from a respiratory point of view.
Great, thank you so much. And our last question is also sort of looks at another element of COVID, not necessarily extrapulmonary, but this is from Emeka Elumelu, who says, thank you for the answers for their previous questions. And then their question is there a possibility of PTSD post-COVID?
Absolutely, without doubt. I think we are working quite closely with our palliative care colleagues, and through their supportive interventions with patients with COVID-19, they've definitely seen the mental health impact of COVID-19, of which, PTSD is unfortunately quite a severe, is on the more severe spectrum of mental health concerns, I think it's definitely something that we need to be aware of. And as I said earlier in the presentation, I think we're starting to become more comfortable with the acute presentations of COVID-19, but we definitely are still very much in the dark and trying to learn about long-term sequelae of COVID-19. And I think mental health care concerns are going to become much more of a hot topic for us as we move forward into the long-term sequelae and managing those.
Yeah, definitely agree. And thank you for that response. Just as a quick aside to that, our presentation or webinar previous to this week was about the impacts of COVID-19, the psychosocial impacts of COVID-19 on emergency care staff. So not necessarily on patients, but definitely the impacts of COVID-19 on emergency care staff and how that affects people mentally, with PTSD included. And as a result of that conversation and the clear need to have these discussions, both in terms of the impact on emergency care staff, but also on patients, we are working to develop more webinars that focus on sort of this mental health element to COVID-19 that will, of course, be present and important to manage in future months. So please look out for those webinars, and we're hoping to get those ready in the next couple of weeks for you all. So that does conclude our webinar for this week. Really appreciate the engaging questions that you all asked, and we are looking to create a tutorial for how to enable your audio. So I know some of you just didn't have audio capabilities, but we are working to also create sort of an audio tutorial to ensure that you're all able to follow along and enable your audio without me just dictating it to you through a screen. But a huge thank you to Dr. King for such an informative presentation and for giving us some real important case studies and some sort of hands-on engagement with what you're going through and what you're sort of managing in Cape Town. And thank you so much for the work that you're doing on these rapid reviews. We've had such positive feedback from it and a lot of interest just through this webinar in terms of accessing those resources. So thank you so much for presenting and for providing all of those answers to so many questions that were asked here.
My pleasure. Thank you very much. I was actually thinking I probably should have made my presentation longer, so I was in the hot seat for less time. But thank you very much for your questions. I'm really grateful for the opportunity.